In episode 92 of Dermatology Weekly, Dr. Candrice Heath hosts a conversation about OCT imaging in different skin types and the new opportunities for inclusion. And in the news, expanded indications for apremilast are on the way. This is Dermatology Weekly by MDedge, where we bring you the latest in dermatology news, followed by a peer-to-peer conversation about the latest in dermatology. Coming up in peer-to-peer, Dr. Candrice Heath welcomes Dr. Steve Daveluy and Josèe Smith to talk about opportunities for inclusion and equitable treatment of patients with skin of color. And coming up in the news today, an immunotherapy combination produces a high response rate in melanoma. And in our COVID-19 update, blood glucose on admission predicts COVID-19 severity in everyone. But our top story today, big changes could be coming in the use of oral apremilast, which is currently approved for moderate to severe plaque psoriasis in adults. This prediction comes from Dr. Bruce Strober, who spoke at the Medscape Live's annual Las Vegas Dermatology Seminar, which of course was held virtually. Dr. Strober is a dermatologist at Yale and at Central Connecticut Dermatology. He said that there will be a pediatric indication down the line as well as a mild to moderate indication for psoriasis. He clarified that clinicians can use apremilast in patients for whom topical therapies are typically the only therapy used. In fact, he said that he thinks a mild to moderate indication could be approved in 2021. Amgen, the manufacturer of apremilast, recently announced positive top-line results from the ADVANCE trial, which is a phase 3 study of 595 patients with mild or moderate psoriasis. The researchers in ADVANCE randomly assigned patients to receive either the approved dose of apremilast, which is 30 milligrams twice a day, or placebo for 16 weeks. This was followed by 16 weeks of open-label apremilast for every patient in the trial. While the full findings haven't yet been published, Amgen has announced that the results were positive for all primary and secondary endpoints, and that the company plans to file a request for an expanded approval with the FDA. So let's get to the possible pediatric indication. In a recently published phase 2 study of apremilast in 42 children and adolescents with moderate to severe plaque psoriasis, researchers found that a weight-based dosing scheme is the best approach for pediatric patients. The study showed that dosing apremilast at 20 milligrams twice daily in youths weighing not more than 30 kilograms and 30 milligrams twice daily in those who weighed more provided a pharmacokinetic exposure similar to that achieved with apremilast at the standard dosing for adults. And researchers also reported that most participants liked the taste of the tablet. Apremilast works by blocking phosphodiesterase type 4, thereby reducing cyclic AMP metabolism with a resultant increase in cyclic AMP levels. Cyclic AMP is a regulator of inflammation. Boosting its level has the effect of decreasing tumor necrosis factor and other pro-inflammatory cytokines while increasing anti-inflammatory mediators like interleukin-10. Dr. Strober characterized apremilast's efficacy as modest by contemporary standards in adults with moderate to severe psoriasis, with weak 16 PASI 75 rates of about 30% in randomized trials, compared with 5% in controls who received placebo. He also considers apremilast to be a good option in patients with moderate disease who are needle phobic, as well as those who are adverse to the inconvenience of lab monitoring. The drug is useful in treating psoriasis in especially challenging locations. Apremilast is specifically approved for scalp psoriasis, and Dr. Strober has anecdotally found it helpful in patients with palmoplantar psoriasis or genital psoriasis. And we move now to a neoadjuvant immunotherapy combo for melanoma. The combo therapy is safe and efficacious for patients with high-risk resectable melanoma. This is according to the results of a phase 2 trial that was reported at the 35th anniversary meeting of the Society for Immunotherapy of Cancer. The two agents in the trial are the PD-1 inhibitor nivolumab and an investigational drug called CMP-001. CMP-01 is a toll-like receptor 9 agonist that activates tumor-associated plasmacytoid dendritic cells. In the trial, researchers enrolled 31 patients who had resectable stage 3 BCD melanoma who had clinically apparent lymph node disease. The patients were treated with 3 cycles of nivolumab given every 2 weeks. They also received 7 weekly injections of CMP-001 subcutaneously and intratumorally. After surgical resection, the patients received more of the same immunotherapy. At a median follow-up of 15 months, 60% of patients had a major pathologic response. Half of patients had a complete response, and 10% had a major response. About 70% of patients had any pathologic response. Biomarker analyses showed that response was associated with evidence of immune activation, both in the tumor and in the blood. With immunotherapy, the density of CD8 tumor-infiltrating lymphocytes increased by a median of about 10-fold in pathologic responders. That's compared with an increase of only 0.8-fold in non-responders. So how about the survival data and the safety data? First, survival. The researchers reported that patients had a better median relapse-free survival if they attained a major pathologic response. The landmark one-year relapse-free survival rate was 89% for major pathologic responders and 90% for all pathologic responders. Now for the safety data. The researchers reported that overall, almost 23% of patients experienced grade 3 treatment-related adverse events, the majority of which did not require medical intervention, and none of which delayed planned surgery. There were no grade 4 or 5 treatment-related adverse events. Cytokine release syndrome was uncommon. And finally today, hyperglycemia at hospital admission is a key predictor of COVID-19 related death and severity among non-critical patients, regardless of the patient's diabetes status. This is according to new research from Spain published in a November edition of the Annals of Medicine. In the study, the researchers found that among the more than 11,000 Spanish patients who had confirmed COVID-19 between March and May of 2020, admission hyperglycemia independently predicted progression from non-critical to critical, and death. This was regardless of prior diabetes history. Those with abnormally high glucose levels were more than twice as likely to die from the virus than those with normal readings at about 41% compared with about 16%. These patients also had an increased need for a ventilator and ICU admission. This study differs from some of prior research in that it examines outcomes by admission glycemia rather than during the hospital stay, therefore eliminating the effect of any inpatient treatment such as dexamethasone. Although blood glucose measurement at admission is routine for all patients in Spain, as it is in the US and elsewhere, a mildly elevated level in a person without a diagnosis of diabetes may not be recognized as important. The researchers reported that in patients with diabetes, clinicians start the protocol to control and treat hyperglycemia during hospitalization. However, in non-diabetic patients, blood glucose levels under 180 and even greater are usually overlooked. This means that there's not a correct follow-up of the patients during hospitalization. The researchers added that clinicians need to pay attention to the patients who develop hyperglycemia from the very beginning. And that's it for the news portion of Dermatology Weekly. When we come back, peer-to-peer with Dr. Candrice Heath. Welcome back to Dermatology Weekly. It's time now for Peer-to-Peer. Please welcome the host of this segment, Dr. Candrice Heath.
I am Dr. Candrice Heath, guest host for the Dermatology Weekly podcast. And today we are very excited to have the winners of the crowd favorite Skin of Color Society, Skin of Color Scientific Symposium. So we are excited about interviewing these two special guests, and they're going to tell us all about their research. The first one is Josèe Smith, a medical student at Wayne State University School of Medicine, and Dr. Stephen Daveluy, the program director at the Wayne State Department of Dermatology. Welcome, welcome.
Thank you. Thanks so much for having us.
All right. So I will just give all of our listeners the title of your winning poster. And the title was Quantitative Analysis of Skin Attenuation Using Optical Coherence Tomography. So, I had to do a little bit of research to even prepare for this, interview, because that was very, very fancy. So I found it very interesting, and I think our listeners will as well. So let's dive right in. So I'll start with Dr. Daveluy. why did you select to research this area in the first place?
Yeah, thank you. We have another colleague who's on the poster who works in our biomedical engineering department and who's really interested in skin imaging. And there's kind of a lot of research coming out in the area. It's been slow because it's always been so easy to do a skin biopsy that there wasn't a lot of demand to get a non-invasive way to do it. But now that the technology has gotten better, it's sort of catching up. And so we came up with this idea of, one of the challenges with optical coherence tomography, it almost looks like an ultrasound picture. And so people have to learn how to read that and how to understand what it means. And it takes some time, which presents a barrier. So we talked about, could we have some software that would actually help? Could it sort of help you figure out what's going on in the picture? Because there's a lot in those pictures and our eyes can see it. But when you start really analyzing all the different hues and shades of color and differences, the computers can see a lot more. And then we said, all right, well, if we're going to look at that, we need to know what the baseline is. And it's important to know how that baseline is different for different people and different skin types. And we particularly wanted to look at different skin types and skin tones, because that's been an area in dermatology that we haven't always been very good about including in our research or in our textbooks. There's a lot of recent evidence showing that our textbooks don't include pictures of patients with skin of color, and things can look different. And there's a lot of research or data that shows the old research didn't always include skin of color patients in things like big psoriasis trials. So we said right from the get-go, we want to make sure we're inclusive and we look at all the different skin tones and see how these different features vary among different skin types and skin tones and ages and sun damage. And then we can figure out, once we know what normal is, how to assess pathology in the skin.
Oh, wow. I think that's a great way to approach it. Going into the project, just saying, wow, we're going to put out some data that can definitely be used for years to come, especially with people with different skin tones. I think that's great. And Josèe, when this research project presented itself, what did you think about the topic? I mean, even as a dermatologist, this is sort of a new area for me. But when the project presented itself to you, what did you think about that?
So I was really interested from the beginning. I had seen, I volunteered and helped with the OCT imaging prior to starting with the project. So I'd seen the images and how they could show you a cross-section of the skin, but it looked black and white. So being able to quantify the properties and see what those differences are that you can't see with the eye, but that exist in different skin types and in different age groups was really interesting. Previous work in our group had shown that older skin that had sun damage or older skin had some differences in the property on OCT imaging. So I knew that like doing this work was going to be significant and that what we found was going to be useful in the future, which I thought was really important, especially as technology becomes more available to like analyze the skin non-invasively. Having something that can help sort of objectively to see what the differences are in different skin types is really important.
And Josèe, in doing the research, as you were participating in the project, did you think to yourself, okay, this is something that's only going to be used in research? Or were you thinking, okay, somehow this may be clinically relevant to the practicing dermatologist one day?
I definitely thought it would be to the practicing dermatologist one day. I knew that we were already taking pictures of melanoma after it was biopsied with OCT. And so being able to, in the future, avoid biopsies, because we know that they can be painful and take a long time to heal, and being able to image the skin using something that's non-invasive and shows you what the skin looks like in real time would be tremendously useful as a practicing dermatologist. And then having something that could show you what the differences are, not just what you're looking at, but is that normal for a lighter skin type versus is that like abnormal in somebody that already has sun damage, and being able to sort of objectively figure out what isn't and isn't right based off of what you're seeing.
And Dr. Daveluy, I know that you can relate to me and how hustle and bustle and fast dermatology practice can be. So where do you see this clinically fitting in? Of course, I immediately thought about our people who were clinician scientists. Okay, he wanted to make that jump, and also people who studied pigmented lesions, who really needed to know even more information because they were taking care of complex patients. But where do you hope to see this fitting in clinically for the regular practicing dermatologist?
That is kind of the golden question, because like we said earlier, biopsy is so easy and so quick, and we're already used to it. We have the equipment. This has this new learning curve. So we're hoping that with research like this will become more accessible to people, because maybe you can quickly take an image and the software can sort of make a suggestion to you, like this may be a basal cell, this may be psoriasis, and still leave it to the clinician to have, the final say. But if it would be a little bit easier, because in a sense, that's what we have to compete with, is the ease of biopsy. And like Josèe said, it is a challenge. Sometimes there's sensitive areas, it's always a harder choice to biopsy someone's face because it leaves a scar, and usually it looks okay, but it does leave a scar. So we're hoping that may be where it can come into play. And then two, the nice thing here is the threshold for OCT is going to be way lower than the threshold for biopsy, because there is no complication from taking an image of the skin. So if you aren't really sure, maybe you'll take an image because you don't have to leave a scar with it. But like you said, it's not quite there yet. It really does kind of slow things down when we use it in clinic and we say, all right, well, let's go get an image of this real quick. And it adds a lot of time. And I will say sometimes my residents are like, oh, do we really have to take an image of this patient? Do you know how many are waiting right now? So we're still finding that place for it to fit into clinical practice. But hopefully research like this will push it toward being more convenient and more of an option for people in practice.
I think you're exactly right. And, often we leave out the patients, like what they would prefer. And as someone, I'm also a pediatric dermatologist and I also take care of adults. So anytime I'm presenting options to the family about all the different things that we could do to take care of the issue that the child has, the child is always going, no, no, no to anything, that is invasive or is going to hurt even just a little bit. So I think that patients probably would be very receptive to this. So I'm excited about where your research will take us down that path.
Mm-hmm.
So let's move into some of the results that you found, some of the things that we can really hang our hats on. So let's dive into some of the data. So Josèe, you gave a very nice review in the Skin of Color Society, the symposium that they did. You did a oral presentation that was great, and you talked about how the skin tone can actually affect the OCT readings.
Yes.
So can you give me some summary information about that, some take-home points for our listeners?
So overall, I'll just explain the attenuation coefficient first. So that was the property that we analyzed with respect to the Fitzpatrick skin type. So the attenuation is an optical property measurable on OCT that correlates with how easily light penetrates a material or is reduced after taking into account light scattering and luminescence. And then we compare that to the Fitzpatrick skin type, which is a classification system based on a person's skin color, as well as their degree of sunburning and sun tanning. So we found that the skin attenuation on OCT imaging increased with lower Fitzpatrick skin types or lighter skin tones, and it also increased with older age groups. And so that finding may result due to the influence of skin pigmentation on light transduction or variations in the stratum corneum with age, which we know is the layer that is primarily responsible for light scatter. And it also gains thickness with age and photo damage. And there are also variations in some of the biophysical and mechanical properties of that layer with respect to different racial and age groups as well. Also, we saw that there was an increase in skin attenuation in sun-exposed skin in lighter skin tones, specifically after the sixth decade, which we didn't see in darker skin tones, which was also interesting.
Yes, very, very interesting, and definitely something that you have to read again and again to really make some conclusions. But I definitely saw some correlations that will be very helpful to other skin of color experts. I saw some correlations that will be helpful for people who take care of our older population, and also our cosmetic dermatologists. Also, there is some helpful information here. So it really can touch a lot of people. So, Dr. Daveluy, what did you think about the impact of skin tone on OCT readings?
Yeah, we found a couple interesting things like Josèe kind of mentioned. One of the things we did is we looked at the skin of the hip and of the forehead, and we thought the hip is photoprotected unless someone has very risque clothing choices. It usually doesn't get too much sun versus the forehead, of course, gets sun exposure a lot. And we noticed in the hip, there was a trend. It didn't quite reach significance, which may have been due to our number of patients. And maybe if we had more, we could have gotten it there. But there was a trend for the darker skin types to have lower attenuation coefficient, which, like Josèe said, that means the light kind of traveled through the skin without getting reflected and refracted too much. And we thought that that was probably due because the differences in Fitzpatrick skin type are due to differences in the melanin content and distribution. So in darker skin types, there's larger melanosomes and they're distributed very evenly and singly across the skin and the keratinocytes, versus in lighter skin types, there's smaller melanosomes and they're clustered in groups. And the wavelength of the OCT machine is in the near infrared range. It's around 1500. And so that doesn't get absorbed too much in melanin, but the clustering of the melanin would probably affect it more, because instead of it sort of being this even layer of melanin that would sort of give it a low attenuation coefficient, those clusters and chunks that we see in the lighter skin types would influence and increase your attenuation coefficient more. Then when we looked at the head compared to the hip, we saw that trend. When we looked at the skin of the head, it was actually a significant difference where the darker skin types had significantly lower attenuation coefficient than other skin types. So that kind of tells us two things. One is there's a trend just from your intrinsic skin type without the sun exposure. But then when we add on the changes with sun exposure, it becomes significant. So there's sort of a combination of two things. And we aren't really sure what that means yet, because it's still early, because the sun exposure piece is a little difficult, because you say, well, does that mean that there's fewer changes due to the sun exposure, or just different changes that we see in different skin types with prolonged sun exposure? So an area to kind of do more work in the future.
So you had a wonderful study, and then some other interesting scientific points came up. So I love when research projects happen and then you have further questions to answer with more research. I mean, it's great. Great research begets great research. I think this is very, very exciting. So I'm glad that you dove into something that was, not a popular topic to study, but definitely something that's going to make an impact on our field for sure.
Mm-hmm.
So we kind of talked about, some of the factors other than the skin tone. We talked about the location on the skin that could make a difference, whether it was sun exposed. Are there any other factors that we didn't talk about that can affect the OCT readings?
So those were the factors that we looked at as far as like categorization, unexposed versus exposed skin, the 3 age categories, and then we grouped the Fitzpatrick into 3 groups, 1 and 2, 3 and 4, and 5 and 6. But looking deeper into the skin, there are more factors that could explain the differences that we see in OCT images. So for example, with the epidermis, we know that there are, like I mentioned, some biophysical properties that are different, such as like in the compaction or in the amount of lipid content in the stratum corneum. And then that can also explain some of the light scatter. There's also been previous studies that mention that the stratum corneum gains thickness with age and with photo damage as well. And in addition to that, the dermal epidermal junction also has age-related and racial differences in thickness, compaction, and permeability. And that can also affect the OCT readings. Light penetration and OCT readings can also be affected by ground substance and elastin content and organization, which are also impacted by age and sun damage as well.
And we saw, so another thing like Josèe was mentioning is with the age, we saw a significant increase in the attenuation coefficient, which tells us that in the epidermis, that is, and it tells us the epidermis is maybe less organized with age, which we know can happen. Sometimes there's variability in the cell size and shape that we see as sort of a sign of aging. Unfortunately, we didn't quite have enough numbers because we'd really like to see, okay, which factors are due to intrinsic aging and which are due to extrinsic aging. So sort of sun protected sites, how much did age influence, which it was significant at both sites, but our numbers weren't big enough to kind of see what was the impact of sun damage. So how much more change did we see in the forehead compared to the hip? But it was significant at both sites. So with age, there are significant changes, which has a big impact if we're looking at, like you mentioned earlier, doing imaging on a pediatric patient versus a geriatric patient. We got to understand that there's already going to be some differences in the skin, and we can't sort of look at them both the same to try to find pathology because it's just going to be different at baseline.
Yeah, I think you're exactly right. Exactly right. And Dr. Daveluy, are there conclusions to your study that you think, okay, these are the most important conclusions, takeaways that I want people to really hang on to from our research?
Absolutely. So the big conclusion is that if we want to kind of use this extractable data that we can pull from the images and assess with software, we really need to know the baseline variation across ages, skin types, sun damage. Luckily, everyone does have a built-in control. When we take our images, we can go to adjacent normal skin and get a little image there. So that's kind of become our standard when we're doing our imaging now, is to image the rash or the tumor and then also image the adjacent normal skin, because that way we can assess that prior to assessing it. It gives you sort of a baseline. And then from our study in particular, we found that there seemed to be lower attenuation coefficients with darker skin types, and the attenuation coefficient increased with age. Like I mentioned, we sort of know some of the changes that we see based on melanin distribution and based on skin aging that suggest these might be what the attenuation coefficient is measuring, but we aren't entirely sure yet. So as you mentioned, it kind of inspires us to do more work and figure out exactly which of these factors affects it, because then that may help the software to make decisions. If it knows this is a sign of sun damage, maybe it will be more likely to diagnose an actinic keratosis, just like when the dermatopathologist is looking at the slide and says, oh, there's a lot of solar elastosis here. That leads me to think this is probably a squamous cell or an actinic keratosis.
Yes, I definitely agree with that, and it reminds us that yes, there is a science to seeing patients, but also there is an art to what we do as well. So we take what we see, but then there are all these other factors that go into us making the leap to the diagnosis that's specific for that patient. So I think you said that very well. And any closing thoughts, Josèe, that you have to add to the conclusions, if anything?
I agree completely with what Dr. Daveluy said. I think that we showed that the attenuation coefficient provided by OCT correlates with a lot of the differences in skin composition linked to skin type, sun damage, and age. And I think as skin cancer is becoming more common as our population gets older, it's more important that we have less invasive means of diagnosing skin cancer. And then even though skin cancer is less common in skin of color, we know that melanoma and other types of types of skin cancer are usually diagnosed at later stages and more complicated stages. And so having earlier ways of detecting skin cancer and skin of color, I think, is really important for the future.
I think that's wonderful. Definitely great conclusions, great takeaways. And I know that there were other people who were intimately involved with your this research project. Do you want to go ahead and mention some of them?
So of course, Dr. Mohammed Reza Nasir Abenaki, he is the biomedical engineer that sort of kickstarted the project, built the OCT imaging device, and was a huge mentor in creating and helping me with this study. now Dr. Josèe, he's a medical student at the time, but he was tremendously helpful, sort of came in and helped with imaging as well as preparing the poster, and just along the way was really, really helpful as well. And Dr. Maragon, our chair at Wayne, also a mentor and very helpful. And of course, Dr. Zhu, or Miss Zhu, Kyun Zhu, who was the biomedical engineering master's student at the time of the project and did all of the statistical analysis for this study, which of course is incredibly helpful in understanding what the results of the study were and what exactly we found in the images. So thanks to all of them.
Yeah, and big thanks to Kwayun Zhu and Dr. Avenaki, because they did all this complicated physics stuff that I still don't fully understand and have to reread every time I look at our data. So big shout out to them for doing the things that I don't even fully understand.
Yeah, it's a village when you're doing research. It's a village. We need scientists that study at the benchtop and do physics, and then we also need dermatologists who are seeing clinical patients to come up with those questions and have the volume of patients to contribute to studies. Well, absolutely. This has been a great conversation. I do want to say again, congratulations to you both for your winning poster. You won the crowd favorite for your poster, quantitative analysis of skin attenuation using optical coherence tomography for the Skin of Color Society Scientific Symposium. And we want to thank the Skin of Color Society for allowing us here at Dermatology Weekly to interview the winners. And I'm sure that our listeners and readers will learn a lot from your research. And of course, you know who I am. And if you don't, I am Dr. Candrice Heath. I am a guest host here at Dermatology Weekly. And I hope that you have a wonderful rest of your day. Thank you for listening.
And that's it for episode 92 of Dermatology Weekly. Dermatology Weekly is produced by MDedge editors Elizabeth Meshkati, Melissa Sears, and Alicia Sunners. All MDedge podcasts are produced by our executive editor, Kathy Scarbeck. The host of Peer to Peer is Dr. Candrice Heath. You can email us at podcast@mdedge.com.